Hello, everyone. This is another presentation in the post-acute COVID-19 exercise and rehabilitation project series. This presentation is on inpatient facility core competencies, basics for PTs transitioning from another treatment environment. My name is Matt Walko. I'm a physical therapist, ABPTS certified cardiovascular and pulmonary specialist, and I function as a clinical associate professor at Lebanon Valley College in Annville, Pennsylvania. Please note that this course is intended for educational purposes and does not replace mentorship or consultation with more experienced cardiopulmonary or acute care colleagues. This content is current at the time of dissemination. However, realize that evidence and science on COVID-19 is evolving rapidly and information is subject to change. I am a 1999 graduate of College of Misericordia's MSPT program, a 2007 graduate of Misericordia University's Transitional Doctor of Physical Therapy program. I earned my ABPTS Cardiovascular and Pulmonary Specialist certification in 2009. Since 2013, I've served as clinical faculty at the Lebanon Valley College Physical Therapy Department. I have no financial interests to disclose. The overarching objective of this presentation is to help a physical therapist who is currently functioning in a non-inpatient, non-acute care environment to become quickly spun up on major core competencies that are relevant to practicing as a physical therapist in an acute care environment. Examination and treatment of an adult patient in the acute care environment are similar to an evaluation and treatment completed in any physical therapy care environment, of course. However, they are a little bit different because they're marked by a thorough medical chart review, something that's not often available in other treatment venues. We also focus a lot on assessment of functional mobility, as well as screening of relevant musculoskeletal, neuromuscular, cardiovascular, and pulmonary and integumentary systems. Speaking of environmental differences, one of the first things that the therapist moving from a non-acute care environment to an acute care environment will notice is that there are often different special environmental circumstances that we'll have to be very keenly aware of as we treat patients with different disease processes. Many of the pathogens that we'll be exposed to as treating therapists will be germs that we'll have to isolate ourselves from, and in some cases we'll have to isolate our germs from the patient. In the inpatient environment, everyone is assumed to be observing standard precautions for infection control. That includes the assumption that broken skin, mucous membranes, and all bodily fluids are potential sources of infection. This means that before and after every patient, we'll need to perform hand hygiene. You'll often see signs at the doorway that tell you to gel in and gel out. That means that you'll be using some sort of alcohol-based gel hand sanitizer, often provided for you at the entrance or exit of each room. It's strongly recommended, and in fact policy in most acute care hospitals, that you wear gloves whenever you contact a patient. Along with gloves, disposable gowns, face masks, goggles, and face shields will be provided if appropriate. And lastly, to help stop the spread of respiratory germs, we'll, as physical therapists, remind our patients to use good respiratory hygiene or cough etiquette, which typically includes them coughing into their elbow or at least into a tissue or paper towel. These standard infection control precautions are precisely that. They're standard, they apply to everyone. Additional enhanced precautions may apply to patients with certain disease processes. In the acute care environment, there are two types of face masks that you as a physical therapist may need to wear depending on the patient. The first is a simple surgical face mask, and in current COVID situations, most hospitals require all personnel to wear one of these throughout the day. The simple surgical face mask prevents transmission of droplets from you to the patient and to a certain extent from the patient to you. but it does not form a tight seal around your face and does not protect you from airborne particles. An N95 respirator is a different type of face mask that prevents transmission of particles greater than 5 microns, so this helps filter out airborne particles, including viruses. It forms a tight seal around your face, and most hospitals will require that you are fitted for the proper size before you're allowed to work with a patient that requires you to wear an N95 respirator for your protection. The first type of enhanced precautions we'll talk about are contact precautions. And what we're looking at is a disease process that is passed through either direct or indirect contact from one person to another. Relevant diagnoses include the infamous Clostridium difficile, or C. diff, which allows the spread of pseudomembranous colitis and infectious diarrhea. Precautions for contact precautions typically include the following. The patient has a private room or may be cohorted with someone with the same diagnosis. The provider must wear gloves, a gown, a face shield or eyewear if splashing may occur. Patient-specific equipment should be used if possible, and equipment must be sanitized if you're removing it from a room after use. Hand hygiene afterward may require soap and water instead of an alcohol-based sanitizer. Our next set of enhanced infection control precautions are droplet precautions. And what we're trying to do here is isolate ourselves from the patient's droplets that are spewed from their respiratory system during things like coughing, sneezing, or even talking. Examples of diagnoses that are spread by droplets include COVID-19, influenza, and bacterial meningitis. Droplet precautions typically include having the patient live in a private room or possibly cohorted with someone with the same diagnosis. The provider must wear gloves, a gown, a face mask with a face shield or appropriate eyewear. Patient-specific equipment should be used if possible. That includes walkers or other walking devices. That includes exercise equipment like pieces of TheraBand. That also includes stethoscopes that will often be disposable stethoscopes available for use in that person's room. If any equipment is used in that room and has to be removed, it has to be sanitized according to hospital policy prior to its use with another patient. And of course, remember proper hand hygiene, gel in and gel out. Our next set of enhanced precautions are airborne precautions, and this is to protect you from pathogens that will be spread via the airborne route. So you'll have much smaller, what are known as aerosolized particles that can hang in the air for multiple minutes, as opposed to droplets, which are heavy enough to drop within 3 to 6 feet of the patient after they expel them. Typical diagnoses include pulmonary tuberculosis, varicella, and herpes zoster. However, many facilities are now including COVID-19 in airborne precautions as a result of some of the newer testing, which shows that the virus may hang in the air as an airborne particle. Additionally, patients with COVID-19 that undergo procedures like intubation or when they are on certain types of oxygenation may also produce aerosolized pathogen particles. As a result, patients with airborne precautions will undergo the following. Number one, they'll be placed in a private room with negative air pressure to make sure that when the door opens and closes, there is no release of the airborne particles into the hallway. The provider must wear an N95 respirator, gloves, a gown, a face shield or eyewear if splashing may occur. Like other enhanced precautions, they will need to have patient-specific equipment if at all possible. And if equipment must be removed from the room, it must be sanitized according to hospital or other facility policy prior to it being used with another patient. And lastly, hand hygiene is a must, so you must gel in and gel out. Another type of enhanced precautions are neutropenic precautions, and these precautions are enforced when people have a low absolute neutrophil count, such as folks receiving transplants, patients going through chemotherapy, or otherwise significantly immunocompromised. In this case, we have reverse isolation, which means that you're isolating the patient from the germs that you carry instead of the norm, which is where we're isolating ourselves from the germs that the patient carries. In this particular case, you need to observe strict hand hygiene, so gel in and gel out. The provider must wear a face mask. Additionally, gloves are recommended, and the patient must wear a face mask if they mobilize out of their room. This slide is an illustration taken directly from the CDC website. It explains differences in preferred versus acceptable alternative COVID PPE. While it's classified as a droplet-borne disease, evidence shows that it can be aerosolized under some conditions. If available, the CDC recommends that healthcare workers who are caring for patients with COVID-19 wear an N95 respirator. This slide and the following slide are taken again directly from the cdc.gov website that describe donning and doffing PPE, so the order in which you should put on and then take off your personal protective equipment. Unfortunately, the nationwide PPE shortage made completing a video on proper PPE donning and doffing impossible. However, this slide and the next slide show the recommendations for donning and doffing of PPE. Please note that each facility may have minor alterations in these donning and doffing procedures based on their policies. You may want to pause the video at this point to take some time to review all of the bullet points on this slide. On this slide are the doffing recommendations in order directly from the cdc.gov website, just like the donning procedures were listed on the slide beforehand. Again, please take a minute and pause this slide when you have a second to review the entire procedure. Please remember that these are general guidelines from the CDC. Many facilities, as a side note, recommend removing the gown first by pulling on the front of the shirt part of the gown. And as you do that, you're going to tear the gown ties in the process. You'll continue to pull off the entire gown toward your front, eventually balling up the gown and the gloves in one mass. And then you dispose of the gown and gloves and perform normal hand hygiene, and the rest of the bullet points apply at this point. Again, please take a minute to review this slide in totality. Okay, now that we have PPE taken care of, let's take a look at some other nuts and bolts competencies. The first one will be a medical chart review. Often, seeing patients in non-hospital environments doesn't allow one the luxury of reviewing a complete medical chart. Reviewing the chart in an acute care environment, however, is essential, as many things can change quickly, and there will be important information placed throughout the EMR, the electronic medical record. The following slides provide you with a primer for exploring the mountain of information that's at your fingertips. Please note that numerous EMRs exist, each with their own quirks, shortcuts, advantages, and disadvantages. It's recommended that you spend a little bit of time getting in-serviced on your facility's EMR so that you can be efficient with the amount of information that's given to you. A few things that I think are important to do for every patient. Number one, verify that you have a valid physical therapy order. It is possible for a patient to show up on a physical therapy caseload and the order may have been discontinued, or it may have been entered in error, or it may have been entered by somebody that is not a participating provider. This unfortunately does occasionally happen, so it's on us to make sure that our order is valid. Once you have that, I would start with reading the admitting physician's history and physical exam. Then I'd move toward any additional specialist consults, like the orthopedic, cardiology, surgical consults, etc. I'd then move on to review the daily physician progress notes. I then would correlate those with the daily physician order sheets. Be sure to note that any ordered activity restrictions, including things like weight-bearing status, extremity range of motion precautions, need for equipment when out of bed, etc. are observed and followed. Additional items you want to look at are reviewing relevant diagnostic imaging reports, things like ECGs, CT scans, MRIs, X-rays. Review the relative laboratory data. Review the procedures that the patient has had completed and that may be scheduled, and consider what you should or shouldn't do in light of those procedures that might be scheduled. There might be things that you need to hold off your physical therapy care for until they're completed. You want to note the patient's current medications and any changes to the patient's medication regimen, particularly medications whose start may cause them to have abnormal vital signs, at least in the short term. Consider things like changes in their blood pressure medication as an example. You also want to take special heed to read the recommendations placed by non-physician consultants like dietitians, case managers, social workers, etc. Additionally, I would take care to read the current nurse's notes, including current vital signs. Another thing to consider observing when you're treating a patient, in fact, before you treat any patient, you should check this out through the patient's chart review, is the patient's desired level of care. Now, levels of care will come in different names depending on what facility you're in. Sometimes they'll call them full code, sometimes they'll call them code blues. There are a lot of different terms for them. But the terms that I have here on this slide are fairly generic, and I think if we walk through them, they'll make a lot more sense if you're not familiar with them. Number one, a full code is exactly what it sounds like. The patient wishes to have all resuscitative measures completed, including things like CPR and defibrillation. This is typically the default standard for patients admitted to the hospital until their wishes are made known otherwise. The next step down from a full code is a limited code. So the patient may opt out of selective resuscitative measures, such as a DNI order. Maybe they wish to have CPR, but they don't want to be intubated for some reason. The third step would be a do not resuscitate order, in which the patient does not wish to be resuscitated if their heart stops, but short of that, they want to have all the medical care that they can have provided to them. A step down from that would be something like palliative care. Palliative care focuses more on the quality of life instead of curative therapies, but some curative therapies may be continued depending on the way that the patient has their palliative care wishes described. One of the last levels of care would be comfort measures. And this is when most medical interventions, including things like antibiotics and certainly CPR and other resuscitative measures, are discontinued. In this case, patients are often given medications to reduce pain, discomfort, or dyspnea, but other curative options are withdrawn. Typically, patients who are receiving comfort measures often are not appropriate for physical therapy. However, if we are able to provide some sort of treatment that is going to be comforting in value to the patient and reducing pain, it may be appropriate to continue limited services in this case. As always, facility policies trump what may be listed here on this slide. So I encourage you strongly to make sure that you review your policy and procedure manual for your facility to learn exactly what your department does with patients with different levels of care. As a PT educator that focuses on cardiovascular and pulmonary physical therapy, I can tell you that it is very common for students who have not been in the acute care environment for a fair amount of time to quickly forget lab values. I can't say because I've never surveyed outpatient therapists or therapists coming from different environments, but I'm going to extend an assumption to say that a lot of these relevant lab values probably aren't the top on folks' mind. And as a result, the next few slides are going to go through some of the relevant lab values. By the way, this is pulled directly from Appendix A, the point of care document from the Academy of Acute Care Physical Therapy, which is a very handy PDF that can accompany this particular presentation. What I'm going to do is go over the normal reference values if they're separated by biological sex or not. We'll talk about the critical values and what that means for the delivery of physical therapy care in the acute environment. So first off, hemoglobin. Hemoglobin, as you remember, is the oxygen-carrying molecule of your red blood cells, and it's measured in grams per deciliter of blood. Normal reference values for men are about 14.0 to 17.4 grams per deciliter, and for women, between 12 and 16 grams per deciliter. The critical values that are listed here are important. Number one, greater than 20 grams per deciliter is often an indication of significant polycythemia. While this condition is quite rare, it does place the person at increased risk for blood viscosity and associated venous thromboembolic disease. If a patient has a hemoglobin greater than 20 grams per deciliter, it's often not an indication to not treat the patient. However, you need to be vigilant for signs of VTE. However, if their hemoglobin is significantly low, and the critical values here are between 5 and 7 grams or less than 7 grams is most of the time what is indicated. Less than 7 grams per deciliter is often the trigger or the threshold point for people to get a blood transfusion. As a result of that, they'll have significantly impaired oxygen carrying capacity. This is often associated with a relative lack of blood volume, and as a result, patients will have significantly impaired oxygen delivery. They'll have difficulty maintaining full consciousness with position changes or exercise. These are the folks that often exhibit orthostatic hypotension when they go to try to sit up or stand up. Some facilities will have a hard stop critical value, some facilities won't. It's important for you to check your department policy regarding significantly low hemoglobin. Hematocrit is very similar to hemoglobin. What this is the percent of red blood cells compared to the entire blood volume in a particular vial. And of course, this is spun up by a centrifuge. Reference values for men are between 42 and 52%, for women between 37 and 47%. Critical values sort of mirror what we see with hemoglobin. So greater than 60% often correlates pretty well with critical value of greater than 20 grams per deciliter of hemoglobin. And we tend to find that a hematocrit of less than 15 to 20% often correlates with that 5 to 7 grams of hemoglobin. And the same rules then would apply for those critical values. Up next is white blood cell count. And white blood cell count is exactly that. It's an aggregate of all the 5 main types of blood cells at once in a peripheral smear. Reference values are between 5 and 10 times 10 to the 9th per liter. If you have significantly low white blood cell counts, it may indicate that the patient, in some cases, will require use of neutropenic precautions. If white blood cell counts are significantly elevated, that in and of itself is not a reason to defer physical therapy. However, the rest of the clinical picture may indicate that the person is having significant infectious problems, and you want to be aware of the associated problems that go with that. In particular, looking at, does the patient have a fever greater than 102 degrees Fahrenheit? That can sometimes be a reason to defer treatment at that time until the temperature is lowered. Next is platelets. Platelets, as you remember, are fragments of cells that help with the blood clotting process. Reference values for platelets are between 140,000 and 400,000 per microliter. If you have a significantly elevated platelet count, again, there's no reason to defer your physical therapy. In fact, mobilization is probably very much indicated because you're going to have patients that have a high risk of venous thromboembolic disease. So you want to keep an eye out for signs and symptoms of things like DVT and PE. However, if your platelet count is significantly lowered, less than 20,000, you may need to consider modification of activity due to the increased risk of bleeding. Modifications of activity could include things like restricting the patient to in-bed exercises, restricting the patient from mobilization or stretching that could put the patient at an increased risk of bleeding. So oftentimes manual stretching is not indicated in patients like this, as would be higher grade joint mobilization. Next, let's move on to some of the electrolytes. These are often going to be found in a bundled test called your BMP, your basic metabolic profile. The first one's going to be sodium, with a reference value of 134 to 142 milliequivalents per liter. When patients have significantly low sodium values, they may develop symptoms of what is known as hyponatremia, which would be a loss of sodium in the blood. And that can be general neurological symptoms like confusion and perhaps lowered states of consciousness. Sodium levels much lower than 120 can put the patient at increased risk for seizure, and when their values are this low, the patient will often be in intensive care, having that monitored and carefully controlled. The next electrolyte is potassium. Reference values of approximately 3.7 to 5.1 milliequivalents per liter. When you have marked increase or decrease, so consider things above like 5.5 to 6 or below 3.0 or as low as 2.5, you're looking at an increased risk for cardiac dysrhythmias. So often patients with severely elevated or severely lowered potassiums will be on cardiac monitors. It is important for you to double check with the physician if the patient has severely elevated or depleted potassium to see if it's appropriate to deliver your care at that time. Another electrolyte is magnesium, whose reference values are 1.2 to 1.9 milliequivalents per liter. Magnesium is another element that is involved in appropriate cardiac conduction, and significantly low levels of magnesium may predispose the patient to ventricular dysrhythmias. Additionally, as a side note, it's also noticed that when patients have significantly low potassium and significantly low magnesium, repletion of potassium will not be corrected until their patient's magnesium levels are brought back up. These three lab values, calcium chloride and phosphate, are here for your reference. Typically, significantly lowered or elevated calcium levels may cause the patient to have muscular weakness. If that's the case and the lab values are extremely high, you may want to consult with the physician to see if there's any reason to defer your therapy at that time. Above and beyond that, chloride and phosphate are listed here mostly as a nice to know for completeness, but really practically extremes of those values are often not in and of themselves a reason to not see a patient for PT. Usually if those values are significantly abnormal, they will have other clinical syndromes which will render it obvious that you shouldn't see the patient at that particular time until they're corrected. All right, as we move on, this next slide deals with cardiac enzymes, and as you would expect, cardiac enzymes will be drawn when people have suspicion of acute coronary syndrome. So they're trying to figure out if maybe the person had a heart attack. Also, you might see that these values are recorded if people are being investigated for heart failure. The first one is troponin. And troponin, of course, is a protein that leaks out of myocardial cells when they're damaged. The reference value for troponin is less than 0.03 nanograms per milliliter. If you see this number being greater than 0.10, it's typically suspicious for acute coronary syndrome until proven otherwise. Significant elevations, like whole numbers of troponin, typically are correlated with some sort of myocardial infarction. One of the most important things to do is, number one, recognize if the value is high, but also look for the trend. What we tend to find is that when someone comes in with an MI and their troponins are elevated, depending on what treatment they get, whether it's heart catheterization, whether it's coronary bypass surgery, if that's indicated, or whether they are simply treated medically, the most important thing you want to do is look for serial values, and you want to make sure that that value is starting to go down. If it's starting to go down, that indicates that the heart is stopped being damaged. There's no additional damage happening at this point. So it's usually safe to start to work with the patient. If you start to see that those values are serially going up and they're not plateauing, it may be more appropriate to defer your therapy until we see a downward trend. Often drawn in the same set of cardiac enzymes is the one listed at the bottom, which is creatine kinase. Creatine kinase is released into the blood by any muscle cells when they're damaged. So whether it's skeletal muscle, whether it's smooth muscle from the digestive tract, or whether it's cardiac muscle. Normal values are listed here. They vary depending on the source. The average normal is between 30 and 170 for the general population, and then there are breakdowns from males and females, and these are based on different reference values. The important thing to note with creatine kinase is it's sort of generic. It tells you that there is some sort of muscle damage. You may see this elevated when you've got somebody with a troponin bump as a result of myocardial injury. You may also find this elevated in patients with significant muscle damage, so anything from maybe a significant crush injury to a muscle, or maybe somebody who is found unconscious on the floor and now has a muscle injury as a result of pressure. You may also find this elevated in patients that have ischemic gut who are in the ICU. Long story short is creatine kinase is elevated whenever you've got a muscle damage indicated via the blood work. It is not in and of itself a reason to stop your physical therapy, but the higher value that is tells you to investigate what muscles are damaged, and that might lead you to modify your exam and treatment. Patients with severe skeletal muscle injury may be prone to rhabdomyolysis, which is going to put those creatine kinase values in the multiple thousands. In some cases, patients suffering from that particular disease may actually require hemodialysis to help clear that creatine kinase from the system. The next lab value that's listed is B-type natriuretic peptide, also known as BNP. It's an amino acid peptide, and the major source of this is the cardiac ventricles. It's released in direct proportion to ventricular volume and pressure overload, and as a result, it's a strong predictor of heart failure. The reference value is less than 100 picograms per milliliter, and that indicates that the patient has no evidence of heart failure. Increases in this value tend to correlate with the NYHA classification for heart failure from 1 to 4. As a physical therapist, I would read this and note that if the patient's levels are significantly high, the person may be in heart failure. So you're going to want to do a very thorough chart review and a thorough patient assessment to find out if the patient's heart failure is now being treated enough so that it's no longer worsening, so that it's starting to go down, and you can start to begin to mobilize the patient. If the patient's heart failure is still active, it may be more appropriate to defer your treatment until their acute bout of heart failure is being treated properly. Up next are kidney function reference values, and the two that we'll look at here are blood urea nitrogen and serum creatinine. Blood urea nitrogen has a reference value of between 6 and 25 milligrams per deciliter. Serum creatinine has reference values for men between 0.7 and 1.3 milligrams per deciliter, and for females between 0.4 and 1.1 milligrams per deciliter. These numbers give us an idea of how well the kidneys are functioning, so that if these two molecules are being cleared fairly rapidly, the numbers will be in the reference range. If the kidneys are starting to fail for some reason, you'll start to see elevations in these numbers. While elevations in these reference values are not necessarily reasons to defer physical therapy, again, clinically correlate this information with the patient's picture. So they're probably in some level of kidney failure. Perhaps this is normal for them. Maybe they've got a varying stage of kidney disease where their values are always high. It's not going to be an issue. However, if this is a fairly quick spike, there might be additional medical problems going on that may preclude you from safely mobilizing the patient. When in doubt, read the reference values, correlate that with additional medical information, and make a sound clinical decision. Okay, our next lab value to look at is blood glucose. And of course, this is a pretty important one. Standard reference values for fasting is going to be between 70 and 100 milligrams per deciliter. When we're looking at somebody with significantly low blood glucose, so less than about 70 milligrams per deciliter, we're looking at patients who are having hypoglycemia, and they'll tend to have symptoms that associate with that. Things like slowed cognition, maybe impaired consciousness. And certainly the lower this goes, the more dangerous it is. So typically you want to make sure that this is addressed in some manner before you treat the patient. Patients with diabetes may have normal blood glucose levels, even a little bit higher than our standard reference values, depending on how well their glucose is controlled. But it's important to be wary of significant untreated hyperglycemia. There are numerous values throughout different pieces of literature. I think a good rule of thumb is if your patient's blood sugar is above 350, you really want to be wary about having the person exercise, because exercising this patient in the setting of a lack of insulin and poor glucose control can actually cause their blood sugar to raise precipitously higher than that 350 level and put them toward diabetic ketoacidosis. If you find that your patient's blood sugar is significantly high, it will probably already be being addressed by the physician and the nurse, but you might want to make sure that you see the patient after a repeat glucose level is checked and that level is down to where it should be. Okay, next we're going to take a look at normal arterial blood gas values. ABGs are typically only drawn in the emergency room when someone comes in and they're not oxygenating well and they need to figure out what's going on, or they're used routinely to monitor patients in the ICU who have oxygenation problems, particularly folks that are on significant amounts of oxygen, and indeed even those that might be mechanically ventilated. I'm leaving this as part of this session, knowing that a lot of folks will not see patients in the ICU, but if you do, you're going to want to use these reference values to help guide some of your decision making. So let's look at some of the normal values first. The first is pH, and this is pH just like we had in normal 7th grade science class. Tells us about the change in acidity or alkalinity, in this case of the blood, because of some physiological change. Normally your body strives really, really hard to maintain a homeostasis level of pH between 7.35 and 7.45. Our next value is PaCO2. So the partial pressure of carbon dioxide in the arterial blood. Normally, we're looking at this value between 35 and 45 millimeters of mercury. This value tells us essentially what the lungs are doing. When lungs are ventilating normally, you'll see a PaCO2 between normal values. If you see an increased PaCO2, you'll tend to find that the patient is in some manner hypoventilating, which means in this case they're not blowing off as much PaCO2 as they should be from the blood. Conversely, if you see a decreased PaCO2, you're going to tend to find that the patient is, for some reason, hyperventilating. So they're breathing more often. Their minute ventilation is high enough that they're breathing more CO2 than they need to. And that may be from a compensatory mechanism or a primary problem. Our next value is PaO2, and that's the partial pressure of oxygen in the arterial blood. Normally, we're seeing values of between 80 and 100 millimeters of mercury. This value can range pretty significantly, and a lot of times we'll see normal values being ranging as a result of age, with folks that are younger tending to have higher PaO2s, and folks that are older tend to have lower PaO2s. The PaO2 gives us clues about diffusion of oxygen through the lung tissues and also about overall lung function. Next is HCO3, which is bicarb, normal values of 22 to 28 milliequivalents per liter. Bicarb tells us essentially what the kidneys are doing and some of the other metabolic processes as well. An increase tends to show bicarb retention by the kidneys, often as a result of a compensatory mechanism for an increase in acidity from hypoventilation from CO2. A decrease in bicarb often shows metabolic activity due to some other process. Oxygen saturation is an indicator of how much, so what percentage of hemoglobin is saturated with oxygen at any one time. In arterial blood gas, this value should be between 95 and 99%, and that should be whether at rest or whether with activity. If we see patients, particularly at rest with impaired O2 saturations, we're knowing that they're having significant pulmonary issues. The last value that's recorded here is the base deficit. The normal is between plus and minus 2 millimoles per liter. And this is the amount of base that must be added to 1 liter of blood to raise the pH to 7.40, assuming a PaCO2 of 40 millimeters of mercury. This is used as a marker of impaired tissue oxygenation. Something else to note that arterial blood gas values, when they're reported, will also be reported with the amount of supplemental oxygen that someone is given. So if it's normal room air, it will say RA. If it is on several liters of oxygen, it will indicate how many liters of oxygen the patient was receiving, or it will be recorded as a percentage of fraction of inspired oxygen at FiO2. By the way, FiO2 at normal room air is going to be 0.21, and as it increases, that means that the patient is having an increased amount of oxygen inspired as a result of supplemental oxygen. There are 4 primary disorders of acid and base disruption, and they are respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. The changes that you'll see in the ABG values, and typically we're looking at primarily your pH, your PaCO2, and your bicarb levels. They're all listed for you here in chart form. And in the next 4 slides, we'll talk a little bit about what it means to be in each of these disorders and what you tend to find from a clinical correlation standpoint. So when we have someone in respiratory acidosis, we have someone with a pH of less than 7.35 and a PaCO2 of greater than 45 millimeters of mercury, with either a normal bicarbonate level if the kidneys have not started to compensate yet, or a bicarbonate level of greater than 28 milliequivalents per liter if the patient is starting to have some sort of metabolic compensation for this. Common causes are obstructive airway disease, thoracic trauma, incisional pain, and medication or drug overdose. And it tends to manifest from a symptom and sign standpoint as things like irritability, lethargy, headache, tremors, muscle twitching, vertigo, tachycardia, and peripheral vasodilation. This is one of the most common disorders that you'll tend to find in patients in the ICU as a result of the common causes that are listed there. So the opposite of that respiratory acidosis that we tend to find in disorders that essentially cause patients to hypoventilate. In this case, we're looking at relative pulmonary hyperventilation. So respiratory alkalosis, too much base, we've got a pH of greater than 7.45. We've got a PaCO2 of less than 35 millimeters of mercury. With a normal bicarb level, if we have not seen a kidney compensation, or a bicarb level of less than 22 milliequivalents per liter if the kidneys are starting to compensate for this. Common causes for respiratory alkalosis include things that would increase your VE. So things like pain with hyperventilation with pain, fever, hyperthyroidism, meningitis, some brain tumors, and then some psychogenic hyperventilation when people are very anxious. It may manifest in multiple ways, including things like convulsions and coma. In lighter cases, it may just give people paresthesias or tingling sensations in their hands and feet, lightheadedness or dizziness, and it may precipitate diaphoresis and palpitations. A metabolic acidosis is often caused by things like chronic diarrhea, shock, sepsis, some forms of trauma, renal failure, and diabetic ketoacidosis. The picture includes one of a pH of less than 7.35, hence the acidosis, a bicarbonate level of less than 22 milliequivalents per liter, and that tells us that the metabolic processes and not the pulmonary processes are the primary driver of this particular disorder. The PaCO2 is going to be normal in uncompensated metabolic acidosis, or less than 35 millimeters of mercury when we have a pulmonary compensation. Metabolic acidosis tends to manifest itself in situations like headache. They'll have malaise and fatigue. They'll feel relatively weak. They may have decreased cardiac function without dysrhythmias. You may see hyperkalemia, and in severe cases, you might find the patient having stupor or coma. When we have a patient in metabolic alkalosis, we have a pH of greater than 745. That's being driven by a bicarb greater than 28 milliequivalents per liter. If you have a normal PaCO2, you're seeing that there's no pulmonary compensation in that case. If you do have a respiratory compensation, your PaCO2 will be greater than 45 millimeters of mercury. Metabolic alkalosis is commonly caused by things like severe vomiting or nasogastric suctioning, excessive use of oral antacids, common use of diuretics. It may also be seen in the clinical pictures of hypokalemia and hyperaldosteronism. It manifests itself as respiratory insufficiency, neuromuscular irritability, reflexia, hyperreflexia, paresthesias, tetany, and in severe cases, coma, seizures. It's important to note for all of these alkalotic and acidotic pictures that you need to take these values and these clinical scenarios in context with the patient's overall clinical picture and not just deciding, oh, they're in metabolic alkalosis, I shouldn't see them. Look at this in context and see if it's appropriate to see the patient based on that context. If you're not sure, remember, it's always good to defer some clinical decision-making help to other folks that are in a good position to help us. Members of the critical care team are typically excellent. So your primary RN, your respiratory therapist, and your critical care physician. So from an algorithmic standpoint, Stiller, Phillips, and Lambert in 2004 put together a really sound algorithm that I think still fits to this day that helps us go through some simple outline steps about how we should decide when we should see our patients. And the next two slides kind of go through this algorithm as you can see. The first thing, of course, is reviewing the medical background and reviewing the medical chart as we talked about. The next step is the patient having enough cardiovascular reserves? So some things that they point out to look for are things like a resting heart rate less than 50% of age predicted maximal heart rate in lieu of another predisposing factor. Is their blood pressure less than 20% variable recently in the same position? Is their ECG normal, or at least is there no evidence of acute MI or dysrhythmia that would stop you from proceeding to mobilize the patient? And are other major cardiac conditions from an acute perspective excluded? And of course, the decision tree says if it's yes, then we can continue. If you're not sure, then discuss perhaps with the senior physical therapist or a member of the medical staff. And if the answer is no, you might want to defer mobilization, at the very least confer with the senior PT or the medical staff to make sure that there isn't a reason to mobilize the patient at this point. And of course, if you do have an outstanding consult with a patient and you're finding a really solid reason to not see the patient at that particular time, you're going to want to make sure that you document that reason very well. You want to make sure that you're very clear in your reasoning, and you also want to document with whom you spoke to help make that decision. And also make sure that if it's true, that the persons involved with the patient's care, i.e. the patient's physician, the patient's RN, are aware of that decision. And then also document your plan for when to become involved. So what parameters are going to look at so that when you can start seeing the patient when they change. So if they've passed the first few hurdles on the last slide, the next step we need to decide is there sufficient respiratory reserve? And by that we mean, is mechanical ventilation able to be maintained during treatment or supplemental oxygen if that's appropriate? Is the respiratory pattern satisfactory? And typically when we're looking at this is less of an issue unless we're looking at somebody with severe neurological compromise where they're having an abnormal respiratory pattern. The top bullet, though, is probably the most important, especially when we're looking at patients in the critical care environment. Do we have an SpO2 greater than 90%? And is it less than 4% recent decrease in SpO2? So are we looking at that SpO2 being fairly stable? Additionally, we're looking at some math here. We're looking at the PaO2 FiO2 ratio, and it says, is that greater than 300? What we tend to find is that when patients have significant oxygenation compromise, that ratio that looks at the PaO2, again, delivered from the patient's blood gas, and the FiO2, which is a percentage of a fraction of expired oxygen, gives you a measure of how much oxygen per regular air the person's getting. If that's greater than 300, that tells you that they've got a decent amount of reserve. When that gets less than 200 in particular, we're looking at evidence of significant oxygenation issues. If there's enough sufficient respiratory reserve, then we can move on with yes, as it says, and we'll look at other factors available. If you're not sure, if the answer is no, the idea is you're going to discuss with a senior physical therapist and or the medical staff, and then make a clinical decision. If in light of the fact that maybe some of those parameters are off, but the risks of not mobilizing the patient are steeper than having them mobilized, it may be appropriate to try to have them move and see what happens, in which case you're going to document that. If after conferring with the medical team, you decide that it's inappropriate to see the patient at that point, that's fine. Document that conversation, in particular that the medical team is aware, and then write down your plan for figuring out when it's going to be safe for moving the patient. So perhaps when the PaO2 FiO2 ratio is greater than 300, we can begin intervention. The third thing is, are all the other factors favorable? And as you can look through that middle block there, we're looking at a lot of relevant lab values. If the lab values are okay, maybe we're okay to move. Other considerations, is the patient's pain controlled appropriately? Are they having a fairly stable conscious state? Can they follow directions? Are there no other neurological contraindications, no other orthopedic contraindications? Again, a lot of this will be coming from the patient's physician order set that says maybe avoiding things like increased cranial pressure or avoiding mobilization until perhaps a fracture is fixed, okay? And then we're looking at other medical stability. If the patient has DVT or PE, have they been cleared for exercise? Is the patient's environment safe? Is there appropriate staffing and expertise available? Again, this comes to the idea of looking at your environment, and we'll talk about that in a few slides next. And then lastly, does the patient consent to treatment? Sometimes patients will need to be gently encouraged to participate. Oftentimes, people feel terrible in the ICU. They don't really want to move. They will have a lot of reasons for not wanting to move around. I do find, though, that for the patients that are able to be spoken with and able to be reasoned with, if we can present to them the idea that getting them off their back into a different position is going to open their lungs up, help their skin, help their muscles, and ultimately help them get home, they're usually much more willing to get up and move around and do what we ask them to do. So give that a try. Just be straight with them, and often that's enough. So if it's a yes, then we can select our appropriate mode and intensity of mobilization and monitoring equipment, and we can go ahead and have them start to move around and get our examination done. If we're not sure, or if there's some factors that aren't favorable, we might want to defer mobilization, discuss this with a senior physical therapist if it's appropriate, or at least members of the medical staff, and then document appropriately. Okay, once we have the chart review completed, it's often wise before you go into the room with the patient that you first speak with the patient's nurse, just to be sure that they're aware of our interaction with the patient, be sure that there's nothing stopping us from providing services at that time. Following that, it's time to prepare the environment. Patients will often have lines, tubes, and other devices connected to them, and it's best to deal with all the stuff attached to the patient before you physically work with the patient and have them start to mobilize. Prior to entering the room, you want to make sure that you have the equipment necessary with you. So if you think you need an assisted device, now's a good time to make sure you have one. Make sure that you get exam and exercise treatment equipment if that's appropriate. And make sure that you take along with you items that the patient may need to keep the patient safe. So things like a pair of hospital socks, a gait belt, that sort of equipment. And as the slide says, consider a few things from a general course, and certainly any practicing therapist can drill down to the nuts and bolts of these concepts, but consider the challenges that are present in the treatment environment. That would be typically things like lines, hoses, maybe an extra person. Is there family in the room that maybe we need to ask to step out just from a space concern? What are the opportunities present in the treatment environment? And then lastly, what are the resources available in the various environments that we can take along with us? All those things you want to be thinking about before you enter the patient's room. Particularly if you're coming from a non-hospital environment where you're used to patients ambulating into your clinic, and now you've got patients in a hospital bed that are tied to what looks like the menu at a fast food restaurant where they have one of everything and two of the special stuck to them. It can be very daunting. You can take heart in a few things. Number one, oftentimes physical therapy departments will have PT aides that may be able to provide you with some assistance in helping the room get prepped. Number two, often nurses or nurses' aides may be available to give you a hand at moving some things around. And number three, most furniture and items in a hospital room are designed to be movable. So you can spend some time moving some things around the patient first to make sure that if you have a really good environment preparation taken care of, you're going to have a much better success when it comes to mobilizing the patient. It is very true that mobilizing patients in a hospital environment is a bit of an art form. The good news is that taking care of this aspect of mobilization in the hospital is grounded heavily in common sense. So if you're able to stop for a minute, think about where you need the patient to go, think about what impediments are in the way to allowing that patient to move safely, you can start systematically moving things so that they are in a spot that allows the patient to mobilize safely and effectively with no risk of removing things like lines and tubes. Very quickly, you will develop skill with preparing the environment and allowing the patient to move despite the fact that they have particular things tied to them. A few simple rules regarding the things that are attached to the patient. Number one, if it's draining something, make sure that whenever possible, gravity is allowing to take that drainage down into the collection bag. So things like a Foley catheter should never be held higher than the patient's bladder. Chest tubes should typically be kept 45 centimeters below the patient's chest. I'm talking about the collection system itself. Additionally, make sure that you're never placing tension on things like IV lines, oxygen tubing, or ventilator hose. And lastly, remember, when in doubt, it's always best to take an extra set of hands with you and potentially not need that extra set of hands, then be in the middle of no person's land with a patient who's trying to transfer and you've got a stretchy IV line and no one else to help you. The more you think ahead first, the more successful and safe you'll practice. Along with figuring out where the lines and tubes are supposed to go, what the natural layout of the room will afford, something else to consider is which direction you want the patient to transfer to. So if you consider the idea of somebody going from bed to chair, which direction you want them to go to. Oftentimes, from a treatment standpoint, we're looking at having the patient move toward the affected side if possible to get them used to if they're allowed to, bear weight on that side or get them to put additional input through that side, say in the case of somebody with hemiparesis. However, if you're thinking about the best way to mobilize somebody, maybe the first time out of the bed, it's often a good idea to go toward the unaffected side so that they can put more weight on the unaffected side. And if they start to lose their balance, you can assist them safely. There are textbook ways of doing this. There are non-textbook ways of doing this. Ultimately, as long as you follow procedures, as long as you follow hospital policies that may be in effect, and as long as you are safe, typically there's no one right answer on how to do this. Now, as we've been emphasizing so far, it's important to think ahead. One of the most important things to do is when you're preparing this environment, and really as you're examining the patient from start to finish, you want to have an idea of what's going to happen when things go wrong or differently as planned. So have a plan A and have a plan B. Be prepared to be flexible. Your patient may be too dizzy to participate upon sitting up. They may become nauseous, or they might start to vomit. They might need to use the restroom. They're going to have some impediments to what your initial plan will be. Expect that going in, and you'll be able to be prepared for when it happens. A lot of this preparation relies on common sense. I think it's fair to expect that someone who has been lying down for a significant period of time can be expected to become orthostatic. So you may need to take more than one attempt having them stand up because of the potential dizziness that they have. Often patients who have undergone surgical procedures with general anesthesia develop significant nausea and vomiting. It's always good to have a small emesis basin or emesis bag nearby so you can grab it within arm's reach. And lastly, it's important to have patient cleansing items near you, as patients in the hospital do have occasional episodes of incontinence, and it's best to be able to manage that quickly, cleanly, and by maintaining the patient's dignity as much as possible. Okay, so we're an hour into this video lecture, and we can finally get to the point where we can organize our examination and we can get into treating the patient. Thank heavens. And the reason for this is there's an awful lot of things, as you can see, to consider before it's time to mobilize the patient. Once it comes down to examining the patient, having them get up and move around, assessing what we need to assess, our physical therapist skills, thankfully, are translatable to any environment, and they're about universal. So at this particular case, you're functioning already as a physical therapist. A lot of this should be easy for you. Okay, a few considerations to think about, and we talked about this already. Number one, before evaluating the patient, consider speaking with the patient's nurse and see what they have to say about us providing care at that particular time. Next, when you walk into the room, of course, you're introducing yourself, and as you're introducing yourself, you're getting an idea of what the patient's cognition is like. Often that patient-therapist introduction helps set the tone for the entire therapeutic exchange, so the more positively we can do that, the better. As we're doing that, we're doing a lot of initial visual inspection. So we're looking at things like, how's the patient postured? Do they look comfortable? Do they look sick? Do they look scared? Do they look well? What kind of lines and equipment do we have? Does it match up with what we expected based on the chart review? Do we have the equipment and the assistance necessary to help mobilize this patient? After that, we get into the nitty-gritty. So let's look at some of the things that you can start to do. The order that I have here, of course, is not dictated in stone. It just tends to follow some logical order. The first thing I tend to do is get a quick set of vital signs, heart rate, blood pressure, SpO2, just to make sure that the patient is hemodynamically stable at that particular time. I tend to also use that time while they're lying down as I'm doing vital signs to get heart and lung auscultation taken care of as appropriate. Typically, it's important for folks, if they've got heart and lung conditions, to get an idea of what those organs sound like and make sure we're not missing any significant problems. We can then start our cognitive screening. You know, is the patient alert and oriented ×4? If not, is this baseline for the patient? If it's a change, what are the potential reasons for this change? Is it an expected change? Do we already have a clue about that or not? Can the patient follow a 3-step command? You know, if they can follow a 3-step command, we know that their cognition is probably in pretty good shape. And it also gives us predictors about whether or not they'll be able to learn well enough to have some carryover to the next session. Some folks suggest even you might want to consider things like abstract reasoning. So they may be able to tell you your name, that they're in the hospital, and what year it is, and maybe who the president is. But if you ask them a question like, does a cork float in water? It really makes their brains process in a way that if they can answer that correctly, tells you that they're in a pretty good state cognitively. Once you've established that the patient can communicate with you effectively and that you find that their cognition is reliable enough that you can trust to a certain extent what they're telling you, it's time to get a good social history. So find out what their living environment is like. You know, is it a 1-story or 2-story home? Do they have steps to enter? Do they have support at home? Is that person that they're living with, if they do have somebody they're living with, are they able to help them if they're not 100% when they're discharged from the hospital? And again, remind them that as you're gathering this information, the reason you're asking this is because it helps you formulate a plan for their physical therapy care and also to help figure out discharge planning. Oftentimes, if you start asking about people's homes without a context, they're a little bit wary about why you're asking this information. If you give them a good reason, they're more likely to be receptive to this. Some additional information you want to find from a social history standpoint, what was their prior level of function like? It may be inappropriate to assume that they were ambulatory beforehand. If they were ambulatory, did they need a device? Get that clarified. Also, a good time to find out if the devices that they have at home are in good shape. They may have brought them into the hospital and you can inspect them and maybe recommend that they have that equipment replaced. It may be that they didn't bring it with them because they were brought in an emergent environment setting. So maybe you can find out, hey, is your walker in good shape? Is your wheelchair in good shape and such? At this point then, once I've gathered the social history, it's time to start prepping the patient's room and equipment as necessary. So move IV lines that are possible to be moved closer to you so that they don't put any stretch from the pump to the patient. Make sure that the equipment that you need is handy, including the bedside chair if that's where they're going. Make sure that the bedside chair has some sort of linen on it, at least a sheet, maybe an incontinence pad, particularly if the patient has been having issues with incontinence. Remember that people are in hospital gowns at this point and may be only wearing their hospital gowns. And after you've assisted with them with that, maybe the hospital gowns and a pair of socks. Please do everything you can do to maintain their dignity, particularly if people are concerned about having their backsides exposed by any means. You always want to make sure that you keep them covered. Oftentimes, as soon as they stand up, it's easiest to be able to tie that gown to make sure that they are not unduly exposed. The next step would be a pain assessment. I'm sure that everyone here is familiar with doing a pain assessment. There may be a particular type of pain assessment that is mandated by the facility. Sometimes it's up to the patient's therapist and up to the patient with what they can handle. Sometimes it's a FACES scale. Sometimes it's a verbal rating scale from 0 to 10. Sometimes it's a visual analog scale. I would then move on to my lower quarter and upper quarter screening with special testing as the screening indicates. Obviously, there might be some special testing if it's appropriate to do in different positions, but some of the basic upper and lower quarter screening can be done with the patient lying down first. Once that's complete, or as complete as we can get it at the moment, we'll start with things like our bed mobility assessment, so they can figure out how well they can roll, how well they can bridge, how well they can scoot. As you're doing this, a few things to consider. Number one, oftentimes people in hospital beds will have their heads of bed elevated. If there's no contraindication to lowering the head of the bed to a flat level, I recommend assessing people's bed mobility with the bed flat, primarily because most people's beds at home are flat. And if we're going to try to incorporate this information into a decision about home discharge, you want to mimic their home situation as much as possible, and that typically includes flattening the bed. Additionally, patients may or may not have some sort of bed railing or sturdy things to hold on to when they roll. So in light of the fact that most people don't have bed rails, I often drop the bed rails down and see if they can mobilize themselves without them. Also, as the patient is moving from side to side, so coming off their back onto one side and then the other, you've got a pretty good time to assess their skin on the posterior aspect of their body. Take the time to do a good integumentary scan to make sure that they don't have things like bed sores or other pressure or wound areas that we need to know about. We can then move on to an assessment of supine to sit transfers. And once they're sitting, do a quick sitting balance assessment. We can do additional limb and trunk screening or special testing while the patient is seated as appropriate. And again, when the person does change position, it's often a good time to get a repeat set of their vital signs and to find out how they're doing subjectively. Maybe their vital signs seem fine, but they may feel dizzy. Now is a good time to see if the patient is feeling nauseous as a result of that postoperative anesthesia. If they're safe from here and they tolerate it hemodynamically, the next step, of course, would be a sit-to-stand transfer. Once they're standing, I usually get another set of vital signs to see if they're maintaining stability, along with an assessment of their subjective feelings. At this point, you can complete a general standing balance assessment, both static and then dynamic if it's appropriate. And if there are standing special tests that you may need to do as a result of an orthopedic or neurological screening of some sort, now's a good time to go ahead and get those done. Of course, the patient may need to sit down and rest in between, depending on their stamina. If all's going well after sit to stand and that standing balance assessment, now's a good time to get your gait assessment done as the patient can tolerate. And please remember, you want to get a set of pre and post ambulation vital signs to compare so that you can assess their exercise tolerance. Afterward, have the patient sit comfortably in hopefully an armed chair and assess their ability to recover that exercise bout. Once we've completed our initial assessment of the patient, of course, we can make additional treatment recommendations. Another set of recommendations we'll often need to make as physical therapists in the inpatient environment are recommendations about discharge planning. This is often a key part of the initial PT assessment in hospital settings, and in some cases might be the only thing that people read about our notes. Discharge planning recommendations may be necessary prior to a patient's discharge home or to another level of care. It's important to remember that while PT recommendations do consider other factors that are considered by other healthcare specialists, say the OTs, registered nurses, dietitians, and such, it may differ from their discharge recommendations. So I always make sure that I'm explicit in that my discharge recommendation is based on my assessment only. In some cases, your discharge recommendations may be automatically assisted by calculation of the AMPAC score. The AMPAC, the activity measure for post-acute care, is a basic mobility scale that assesses 6 domains of patients' mobility. As you can see, we're looking at how much difficulty does the patient currently have turning over in bed, sitting down on and standing up from a chair, moving from lying on their back to sitting on the side of the bed, and how much help does another person need to give the patient moving to and from the bed to chair, to walk in a hospital room, or to climb 3 to 5 steps with a railing. As you can see, these items are often assessed during functional mobility assessment as part of a PT eval anyway. Many EMARs will automatically calculate an AMPAC based on the information that we provide during our initial examinations. Other EMARs will require you to fill this out based on definitions that are available to you in the tool. Once this AMPAC is completed, it calculates a score that helps guide your decision-making for discharge. There are a lot of possible discharge locations that exist. The first one is obviously home, and that's home for whatever the home is for that patient, and it can include things like a private residence, an independent dwelling on the grounds of a retirement community, an assisted living facility, or a personal care home. Based on what we've seen in our examination, the patient may be just fine to go home without any additional services. Maybe they're completely okay. Maybe they would benefit from going home with some supportive services, including some home PT, or maybe they'd benefit from going home, but maybe they need some outpatient physical therapy. Other possible discharge locations would be the not home bucket, if you will. And these can include the ones on the slide and perhaps even other variations. Some common discharge locations include things like a long-term acute care hospital, which is a setting where it's a complete hospital and it's for folks that have significant medical complexity. They're too sick to go to an acute rehab. They're too sick to go to a nursing facility, but they're going to be ill from a long-term, relatively stable standpoint that they're going to need the intensity of a hospital, but not an acute care hospital, short-term acute care hospital. This often includes folks that have significant long healing wounds and perhaps those that have been given tracheostomies that are going to be weaning from a ventilator from a significant amount of time. Another step is inpatient rehabilitation. Often these folks need to meet certain criteria, including the ability to handle 3 hours of mixed therapies per day. Another step would be subacute rehabilitation, which provides rehabilitation at a skilled nursing facility at a less intense level often than an inpatient rehabilitation. So they don't need to meet that 3 hours of therapy a day rule, but they do need to be able to participate in some form of PT. A skilled nursing facility often houses a subacute rehabilitation facility, but perhaps we found that the patient is independently mobile, relatively strong, able to take care of their mobility needs. Perhaps they have some sort of nursing or wound needs that will require inpatient housing. Perhaps at this point then a skilled nursing facility may be appropriate. And then lastly, there are some folks that might be coming from an extended care facility. And in this case, when we discuss this being home, this is a nursing facility of a different type, where the person lives there long-term because of perhaps a mental or physical disability, and we're going to recommend that perhaps they go back there. There are many different approaches to figuring out exactly where someone should be recommended to go out of the acute care environment. I think one of the soundest ones that I've ever seen published by Malone and Lindsay in 2006 is the algorithm that's on the slide at the moment. If you were to take each patient's scenario and run it through this algorithm, it very clearly and accurately predicts what our PT discharge recommendation should be. And I think if you keep a copy of this and follow this closely with all of your patients, you'll make excellent recommendations 99% of the time. The references which I've used that I've also listed on the slides as I've used them are listed here for your reference should you want to read up on any of these pieces of material. I'd like to thank a few people that helped me produce this lecture. Number one is Shannon Walko, MSPT, who's a lead physical therapist at Geisinger Holy Spirit Hospital in Camp Hill, Pennsylvania. She's also my wife of over 19 years, and without her help, I would not be able to produce this. She provided a lot of technical support, and she also provided a lot of perspective, making sure that I added proper things throughout this lecture. Number two is Justin Mierzwicki, who's a clinical assistant professor of physical therapy at Lebanon Valley College, one of my colleagues who has helped me by providing some of the additional supplementary material to this lecture. And lastly, Angela Campbell, professor of physical therapy at Springfield College, president of the APTA Cardiovascular and Pulmonary section, who allowed me to help with the PACER project by producing this lecture. I appreciate all of you very, very much. Thank you.